Hi, I'm Keith Fox from Edinburgh, UK, and here we are at the American Heart Association in Anaheim, California, and I'm delighted to be with Roxana Mehran and Stephan Achenbach, and we're going to have some insights on some of the very interesting studies presented today. Now, Roxana, you're an expert in kidney function as well as many other things, intervention, coronary disease. So tell us, should we really be using bicarbonate? Should we be using N-acetylcysteine for preservation?
So a great study today presented at the American Heart Association called the PRESERVE trial.
Right.
The study was simultaneously published in the New England Journal of Medicine. It's a VA study, really important study, over 5,000 patients.
So about 5,200 patients, but a 2x2 factorial.
Looking at N-acetylcysteine, sodium bicarbonate infusion, and comparing that to sodium chloride infusion and a placebo for the N-acetylcysteine. So it was double blind. I mean, I think it was a really well conducted study.
So these are all people who've got some impairment of renal function. The median creatinine clearance about 50, and 80% diabetics.
Right, so they really enriched the population for the highest risk, and one of the other things that they did really beautifully was that the endpoint was a very hard endpoint. It was death, permanent renal replacement, being on dialysis, or a 50% rise on which was 50% rise over the creatinine at 90 days. As you know, acute kidney injury, you get a bump and then your creatinine goes back. Those wouldn't have been counted in this hard endpoint.
So Roxana, was this enough of a stimulus? In other words, enough of an insult? Most of these were routine angiography, only about 28% were interventions. The dye load about 85 mils.
So a lower dye load, but high-risk patients, which usually don't come to angiography because we're worried, oh, CKD, diabetic, they're going to get acute kidney injury, we don't want to send them. The overall rate of acute kidney injury was 10% across the board, and this really hard endpoint only occurred in about 5%. But you know what? We've known already from one big huge trial on N-acetylcysteine with a placebo in a 2,400 patient study, the ACT-1 study, where there was no benefit whatsoever, and here there was no benefit. And so it shows that.
To some extent confirmation.
Confirmation.
But it also says something to us about a population who've already got impaired renal function, 80% diabetic, who are going through this procedure, and the complication rates are not that high.
They're not that high if you're looking at the rate of a permanent renal damage, but 5% either died or had permanent renal damage. That's a pretty high rate, actually, if you think about it, or some permanent renal damage.
So we've got to consider that.
And you have to take into account that the dye load was really not very high. Typically, we are worried about the patient who comes in, even maybe with an acute coronary syndrome. You cannot prepare them. You end up suddenly with a dye load of 200 milliliters, and of course that's an entirely different situation.
So you've already been adopting this strategy, I think, at home. Isn't that right, Stephan?
Well, in Germany, typically, I practice in Germany, we do not use either of these compounds to prepare patients for...
Because of the previously published trials.
Because of the previously published trial. We know that fluid is given, fluid should be given. We have even conducted our own trials trying to do renal replacement therapy during coronary angiography, which didn't help either. So fluid is probably the best thing we can do for these patients.
So fluid, and these are hydrated patients, but they got saline.
N-acetylcysteine bicarbonate doesn't work. This is the nail in that coffin.
That's the nail in that
100%.
coffin. So definitive answer. Fantastic.
Absolutely.
So let's come to the issue of transfusion at the time of cardiac surgery. So there was a study presented here today, which either had a relatively liberal or more restrictive transfusion rate, and that was at a hemoglobin of 7.5 for the restrictive, and they could be transfused peroperatively or postoperatively, or at 9.5. And it turned out that in the restrictive group, it was 52% getting transfused. In the liberal group, 72%. So what would you expect from this?
Well, first of all, I'm surprised to see the transfusion rates relatively high. I would also be surprised to see that in a restrictive group, the threshold for transfusion would be 7.5, because I would imagine doing a study that you might try to get even lower than that.
Even
because
lower.
In clinical practice, I have to say, in many institutions, 7.0 would be the threshold for transfusion.
Yeah.
So I'm a little bit surprised to see the thresholds as they were chosen in this trial.
Yeah, yeah.
So restrictive, not so restrictive.
So it didn't turn out to be as restrictive as we imagined. And exactly as you said, the trial didn't show any difference in outcomes. So Roxana, what's this going to do to your colleagues' practice?
Well, I think we're still going to be restrictive, probably more restrictive than the restrictive group. I think this liberal use of transfusion at some point is going to come back to harm. There's some real evidence that we really should be more restricted, most likely.
Because there's hazards associated with transfusion, and others have shown hazards with old red cells.
Yeah, I think the need for, the question is there a need for transfusion? And it seems to me liberal versus restrictive here was not really the need. There wasn't sort of a threshold for say who needed the transfusion. And it's hard to kind of take a look at this, and I think both of these arms are somewhat the same, right? And it didn't show a difference.
I think we also have to pay a little bit of attention at what patient group we're looking at here. We're looking at patients who underwent bypass surgery. Now, in interventional cardiology, we're often worried about transfusion thresholds for those who come in with an acute coronary syndrome, had maybe some groin bleeding, and then we should be really restrictive, because the transfusion by itself is more dangerous than the anemia that the patient has, thrombogenicity and all of these things.
So really important point.
But a patient with an acute coronary syndrome that we are typically concerned about is a different patient than the patient who underwent bypass surgery, probably under rather stable conditions.
Yes.
We have to
think
keep
that's a crucial point that you're bringing up.
Okay, that's terrific. So really important take-home messages. Now there's another trial that was done called cruise control. So
it's actually what's called bruise control.
Bruise or not cruise? Bruise control.
Bruise control. So bruise control is actually about more than bruise control, because it's about the hematomas that can occur at the sites of pacemaker implantation, device implantation, and the fact that these aren't always benign. They can have adverse consequences, they can become infected, there can be all sorts of complications. And a prior trial, BRUISE 1, bridged people from VKA, warfarin, to heparin, and then back again, and showed that that had worse outcomes and worse bleeding than just continuing the warfarin.
So these are in patients who require oral anticoagulants, who are coming in for either a pacemaker or is there ablation too, or some kind of an EP procedure?
Not just procedure, usually an implant.
Implanted.
An implant. An implant. And what's happened in BRUISE 2 is they've studied the same question, but in the context of the more non-vitamin K oral antagonists. A third of them dabigatran, a third apixaban, a third rivaroxaban. And they either temporarily discontinued the NOAC for 2 days beforehand, or as appropriate with dabigatran, and then started 24 hours later. And what
or they continued.
Or they
that
continued
was the other group.
all the way through. And what they found was no significant difference at all. So what happens in Germany in terms of practice for device implantation?
Once again, this pretty much reflects our practice. I mean, the bridging was given up long ago because we had the data that switching back and forth between different antithrombotic regimens is too dangerous. It's too dangerous, it doesn't work. So now we typically also work with continued application of these drugs and simply do the replacement therapy.
So
clinical experience is always different, but we don't also
we hold the dose on the morning of, and then we perform, and then we just go ahead with the next dose.
Yeah.
And I think it really depends.
Do you do that?
No, we typically just continue. The thing is that it depends a lot on the patient, the renal function of the patient. You have to take into account the individual drug that is given. They have different half-lives, so you have to probably look at more detail than that. To really find out what to do best in the given patient and with the given drug that the patient is taking. They're not all the same.
They're not all the same, and clearly the renal function is critically important because renal clearance differs with the NOACs. But in terms of the overall message, number one, bridging is out, and number two, temporary discontinuation didn't have a lower rate of complications.
It's very interesting and very important. It's going to make life a lot easier.
A lot easier. So think about outpatient procedures, all of these things. But once again, you know, even an implant or a device change is not the same as the other one. One goes submuscular, the other one is subcutaneous, and we will have to look at all of this data to see whether you find subgroups.
And you know, I think one needs to look at the more complicated procedures. So these weren't all very complicated procedures, but for the standard device implantation, I think it's been very helpful advice. And so really, we've had 3 studies, all of which make life a bit simpler.
Yeah, that's right.
So we shouldn't use bicarbonate. We shouldn't use N-acetylcysteine in terms of preserving kidney function. Being more liberal with transfusion doesn't help us. And here we're saying a complicated regime of stopping and starting with a NOACs doesn't help either. So life's getting more straightforward.
For once, life seems to be getting easier.
A lot of negative trials making life easier.
But with, you know, important findings, I think in the studies. So thank you both so much. You're really important insights. Stephan Achenbach, Roxana Mehran, we've had a really interesting discussion and some important practical take-home messages. Thank you.
Thank you for having me.
Thank you, Keith. Thanks.